Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the JCO article Prospective Molecular Marker Analysis of EGFR and KRAS from a randomized placebo-controlled study of erlotinib maintenance therapy in advanced non-small lung cancer by Wolfgang Burger. The title, Biomarker Selection for Maintenance Therapy in Advanced Non-Small Cell Lung Cancer. My name is Dr. Tony Mok, and I am a professor at the Department of Clinical Oncology at Chinese University of Hong Kong in Hong Kong, China. My oncological specialty is medical oncology with special interest in lung cancer. Maintenance therapy in lung cancer, meaning continuation of therapy after initial response to platinum-based doublets, have been extensively investigated. Continuation of chemotherapy doublet beyond 6 cycles is ineffective and causes additional toxicities. Maintenance therapy with single-agent chemotherapy such as gemcitabine or docetaxel is capable of prolonging progression-free survival, but fails to improve overall survival. Pemetrexed is the only single-agent therapy shown to improve both progression-free survival and overall survival when used in a maintenance setting. Thus, this drug is approved as a standard maintenance therapy in patients with advanced non-small cell lung cancer. Maintenance erlotinib was investigated in the Saturn study. In this study, 889 patients with advanced non-small cell lung cancer who had achieved tumor response or stable disease to 4 cycles of standard platinum-based doublet chemotherapy were randomized to receive either erlotinib or placebo control. The primary endpoint was progression-free survival. The result was published in Lancet Oncology in 2010, reporting improvement in progression-free survival with hazard ratio of 0.71 and p-value of less than 0.0001. Overall survival benefit was also observed with hazard ratio at 0.88 and p-value of 0.0088. The positive result had established maintenance erlotinib as another treatment option for maintenance therapy. However, questions such as how we select patients and how we decide between pemetrexed and erlotinib remain unanswered. This article that is the subject of this podcast reports on the biomarker analysis of Saturn study, which may potentially help to address questions of patient and drug selection. First, I must compliment the authors for their successful effort in collecting tumor samples from majority of patients. They performed the immunohistological chemistry for EGFR protein expression in 742 samples, fluorescent in situ hybridization of FISH for EGFR gene amplification in 488 samples, DNA sequencing for EGFR and KRAS mutation in 437 and 493 samples respectively. Based on the large sample size, together with the correlative clinical data, authors provide robust information on prognostic and predictive power of these biomarkers. They have confirmed that the predictive value of EGFR mutation in maintenance therapy and prognostic value of KRAS mutation. Both immunohistological chemistry and FISH were neither predictive nor prognostic. My discussion will focus primarily on the predictive value of EGFR mutation and its clinical application. We have learned from multiple randomized studies, including NEJ002, WJTOG 3405, Optimal, and UTAC, that biomarker selected patients with an activating EGFR mutation would benefit more from first-line EGFR TKI used compared to platinum-based doublet chemotherapy. Tumor response rate and progression-free survival were improved with EGFR TKI used in this setting. In the clinical enriched study population of IPATH, about 60% were EGFR mutation positive and 40% were negative. EGFR TKI attained longer progression-free survival in patients with EGFR mutation only. Interaction test was strongly positive with p-value less than 0.0001, thus confirming the predictive value of EGFR mutation for first-line therapy. The current article reports significant improvement in progression-free survival in both EGFR mutation positive and negative subgroup with hazard ratio of 0.10 and 0.78 respectively, largely due to the dramatic differences in progression-free survival between the erlotinib and placebo arm. In mutation-positive patient, interaction test was positive, and EGFR mutation is rightfully considered to be a predictive biomarker for maintenance therapy. In contrast to the first-line setting, where EGFR TKI benefit only patients with an EGFR mutation, maintenance erlotinib appear to benefit both patients with and without EGFR mutation. Now, before concluding on the true benefit, we will also examine the overall survival. Maintenance erlotinib did not improve the overall survival of patients with EGFR mutation. This is likely explained by the significant portion of patients from placebo arm crossing over to EGFR TKI upon disease progression. In other words, receiving EGFR TKI as maintenance therapy or second-line therapy at time of disease progression appear to achieve similar survival outcome. We observe the same phenomenon with first-line EGFR TKI in the IPATH and also the NEJ002 studies. The only difference is that comparator was toxic platinum-based chemotherapy. In contrast, maintenance erlotinib had improved both progression-free survival and overall survival of patients without EGFR mutation with hazard ratio of 0.77 and 0.78 respectively. The prime function of predictive biomarker is to select or exclude patients from therapy. I will end by asking some questions regarding the clinical application of EGFR mutation testing in the selection of patients for maintenance therapy. The first question is, should maintenance erlotinib be given to patients with an EGFR mutation? The answer is maybe. If EGFR mutation status is known in treatment-naive patients, EGFR TKI should have been given as a first-line therapy and not as maintenance. If EGFR mutation status is known only after initiation of first-line chemotherapy, erlotinib may be given as either maintenance therapy or second-line therapy. The same argument is true for first-line EGFR TKI, except that the quality of life associated with first-line EGFR TKI was better than with chemotherapy, while quality of life associated with maintenance erlotinib could not be better than placebo. The second question is, should maintenance erlotinib be given to patients without an EGFR mutation? The answer is also maybe. Benefit in progression-free and overall survival was true, but relatively small. Maintenance chemotherapy with pemetrexed is also capable of achieving similar benefit in patients with adenocarcinoma, with hazard ratio for progression-free survival at 0.47 and overall survival at 0.7. To date, there is no direct comparative study between maintenance erlotinib and maintenance pemetrexed. The only subgroup that TKI would have advantage over pemetrexed is patients with squamous cell carcinoma, where chemotherapy had limited efficacy. Therefore, either erlotinib or pemetrexed may be used as a maintenance therapy in EGFR mutation-negative adenocarcinoma. The biomarker was not helpful in this population. In summary, this article on biomarker analysis of Saturn study is scientifically sound and interesting. The data has helped to confirm the predict value of EGFR mutation. However, clinical application would be limited. This concludes this JCL podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.